Awesome. Welcome, everybody, back to My Understanding. Appreciate you guys tuning in again. Love having you here. Today, we've got a very special episode. I'm joined here by a good friend, Dr. Rishi Menon. He is a general cardiologist in the Roseville area, and he's been practicing cardiology for 10 years. He has a real passion for medical education, for trainees, and just physician well-being as well. We've become close over the years as we've met each other at Lifetime, especially through Daniel. So he's the one that introduced us. And Rishi, every time that I've had an interaction with you, it's been super fun. So I appreciate you coming on today.
Yeah, thanks, Jack. I appreciate you too. I think the first time we met, we had kind of an instant connection, and you're just so personable, and you've got a real friendliness and warmth around you. So it's really easy to come and just have a chat with you. Thanks for doing this podcast, and thank you for inviting me.
Yeah, of course. Yeah, I'm glad that I got this opportunity to start something like this and continue doing it. And I've met some amazing people along this journey. So this has been a lot of fun, and I appreciate you joining me for this. I would love to hear kind of a little bit about your story, if you don't mind, because you've been doing this for 10 years, and it seems like you have a really big desire to just like help people. And so I'd love to kind of hear like what got you into this.
Yeah, definitely. And thank you again for the opportunity. So I moved out to the Sacramento area. Gosh, I think it is about 10 or 11 years ago now. From the Midwest originally. I did a lot of my training there. And then at that time I was married. And so we moved out here mainly for my now ex-wife's job. And that's what brought us to the area. That's how I ended up practicing in Roseville. But, it's been an interesting journey because when I got into this, I wasn't super interested in medicine. I actually wanted to be a philosopher, and in my hometown. And yeah, man. Yeah. I think that's actually helped.
I think so. You're a very wise man. So
no, I don't know I think if you live long enough and you don't die, you become wise. I think that's what happens.
Just a natural course of action.
That's right. But, based on kind of circumstances and opportunities, I had a chance to go to medical school, actually kind of right out of high school. They had these combined programs out in Missouri where I'm from. So I went and I said, okay, let me, if I have this opportunity, I'll take it. And over the years, it was kind of a struggle, to be honest with you. It was hard for me in the first year or so, especially being 17 going into medical or into a combined program. And then I had some issues, and I felt like it was challenging. So actually I started to feel insecure, and then I really gunned it because I thought, well, I don't want to be like, I can't be less than. I'm here, I'm doing this. So I was like, I want to be the best at everything. That was my mentality, which it's not always bad, but it really compelled me to just to work really hard and learn things. And I was driven a lot by that for a while. And this is just an honest answer. A lot of this was driven by insecurity at a young age. But I got into it and I actually really liked it. I enjoyed taking care of patients. I enjoyed the science of medicine. When I was doing my training in internal medicine, which is what the first step to getting into cardiology, I really enjoyed cardiology. I thought it was so evidence-based. I thought the heart was fascinating. I enjoyed studying it. So I pursued that. Also, being real, I thought cardiologists were badasses. That's what I thought at the time. We're not. We're just, but
hey, I think you guys are pretty darn amazing. So
so many people are, but young Rishi, I really had a vision of them. But I got into it. I liked it. And now I feel really grateful to know this stuff and to be able to help people in this way. On a personal note, I've had a little bit of a health journey as well. So when I came out here, things were a little rough for me as well. That's been a story of my life. There's just ups and downs, and I struggled, and I had some severe depression. I was not making good choices. I had gotten up to probably about double my current weight, which is around 300 pounds at that time. Real bad depression. I got into drinking too. Never at work, never on the job, but I would work really hard, and then when I was off, I would drink really hard, and then it got worse and worse. And actually, on my own. This could be a whole podcast in itself, but there was a moment where I thought, well, maybe I'm an alcoholic, and I checked myself into rehab and got connected, and that turned out to be the case. But I've been in recovery for 6 years now, or going on 6 years, and it's transformed me, Jack. I mean, it has completely informed my paradigm about how I view health, how I interact with people. I myself have gotten a lot healthier as a result of this. Right? Being a cardiologist, shouldn't I know all the stuff to do? And how did I get to be so metabolically unhealthy? But it was a lot of behavioral things, a lot of mental health things.
Yeah.
So, some of what I share, even with patients, is my journey is I know what it's like to be that way. I know what it's like to not feel health, and then to come back on this journey and feel a lot more vital, to feel a lot more health. I think it really helps to understand that, because somebody who's never really felt that or experienced that, it can be a different situation.
I agree. And I think the idea of you having like all of this knowledge, and so you should know what it takes. And I think there's that good distinction there, because having the knowledge of what to do in the application and the, willpower and desire to do it are very different things. And I think I've talked about this with a couple other people on the podcast as well, of how we can have all the knowledge that we need, but trying to build up that willpower, that like discipline almost, to try and break the bad habits is a very tough thing to do. And you really have to find a way to conquer yourself in order to be able to do those things. So I appreciate you sharing all of that with us. Like that's a great, that is your journey, and that is very unique to you. And so I appreciate you being willing to open up and share that.
Oh, of course, Jack. Yeah. Thanks for creating the space for this.
Yeah, I'm happy that I was able to. Well, I appreciate that. So I wonder, one of the questions that I'm curious for you then is regarding cardiology. One of the things that I wanted to go over was, what are like the symptoms of a heart attack, and how can they differ between men and women? Because I've heard that they do. So I'm curious about that.
Oh, this is a great question. And it's awesome that you're highlighting this. Maybe I could take a step back, and one of the things I like to do with people, and you probably know this, your listeners probably know this, but I just like to review what is a heart attack. And I think some of our terms in cardiology, heart attack, heart failure, I mean, these are so vague, and they sound horrifying, and you're like, what does that mean? I really hope that at some point we rename these things, because these are a little bit of antiquated terms. Like heart attack is so non-specific. But if we could take a step back and maybe talk about what's actually happening to the person inside their body, maybe if I could just take a few minutes, would that be okay?
Yeah, please do.
So a heart attack is a very specific event. And what's happening inside the body at the moment of a heart attack is there's cholesterol that's inside the coronary arteries. Now, coronary arteries are the arteries that supply the heart muscle themselves. And there are three, what we would call major, or the technical term is epicardial coronary arteries. So three major coronary arteries. And arteries carry blood that has oxygen to the tissue so that they can receive the oxygen. Veins are like the return circuit, where they take the blood back from the cells, back from the tissues that have now extracted the oxygen and dumped carbon dioxide into the veins, into venous blood. And that sends it back to the heart, so that the heart can send it to the lungs, grab oxygen again, and pump it back out into the arteries. So these are the coronary arteries. They supply oxygenated blood to the heart muscle itself, which is always working, right? It never gets rest. So it always needs oxygen. It's always working. Now, what happens is we sometimes develop cholesterol deposition inside the coronary arteries, and in other arteries as well, like the carotid arteries, sometimes the leg arteries, or the aorta. But it's a bad place to have cholesterol. And cholesterol, when I think about it, I think of it like rust on the inside of a pipe. Now, the cholesterol that's inside the arteries can cause problems in two ways. If that cholesterol builds up significantly over time, it can narrow the artery so that it has, we would classify that as a percentage blockage. So a totally open artery has zero blockage. But if cholesterol deposits on the inside of that pipe, over time, it can narrow down and cause, say, like a 30% or 70% or 99% blockage. And that's a slow... Oh, go ahead.
I apologize. Sorry for interrupting. I just had one quick question for you, because when you say cholesterol, I know that there's like the two different types. You have your HDL and your LDL. So is there one of those two that kind of causes that like rust in the pipe you were saying? And I think LDL is the bad one. So is that the one that does?
That's exactly right. HDL is kind of like a cleanup molecule. So HDL is what, in a way, is taking the cholesterol out from the arteries or out from the bloodstream to the liver to get metabolized. And LDL is, in a way, like a carrier of cholesterol to the tissues. And so LDL is the problem. LDL is that bad cholesterol.
Okay.
And there's a variety of other forms, but for the sake of this conversation, LDL is kind of the main enemy here. So it's LDL that's depositing inside the lining of the arteries.
Okay, perfect. Thank you so much. Sorry for that interruption.
Please, any clarifying questions, let me know. This stuff, I think about it so often. I want to make sure that it's understandable and relatable to your listeners. So any questions are great. They're welcome. So the other way, though, that cholesterol can cause problems is not so much in the progressive narrowing of the coronary arteries. So going from 0% blocked to 90% blocked over years, decades. But if you have any buildup of cholesterol inside those arteries, which we call cholesterol plaques, so the rust would be called plaques, those plaques can actually suddenly rupture. And the way I think about it is like the arterial lining, the internal lining where the blood is flowing through, is a really sophisticated, it's like skin. It's like a really sophisticated membrane. And if their cholesterol builds up underneath that inner lining, so there's 3 layers to the arteries, but the inner lining, if that's where cholesterol builds up on the underneath it, it can start to push into it and it can crack that lining. So where the blood is flowing. Is that making sense? Like it cracks inward into the artery.
Yeah.
Now, all that cholesterol is real nasty and toxic looking. It almost looks like, I don't want to say sink water, but imagine just like visually something disgusting. And it cracks open, and then the blood that's flowing there recognizes that there's been damage to that internal lining of the artery. And that material, that cholesterol material, is real sticky, and it causes the blood to clot right there where that plaque ruptures. And that's a heart attack. That's the moment of a heart attack, was where that lining blocks and you start to form a blood clot there.
Okay.
And that's really bad, because right now, say I got a 30% blockage in one of my main coronary arteries. Right now, 70% of the blood or the majority of blood is getting through. But if there's a plaque rupture there and all of a sudden I form a blood clot in that area, boom, it's like a car accident on a highway. It shuts down the highway. No blood, no oxygen going to a territory of the heart.
Gotcha. And so the 30% there is based. So is there a way to determine, like, sorry, I'm trying to figure out how to word this. So because you were saying if you have 30% of it kind of closed up, 70% is going through, what would it take if somebody had 20%? Is it still possible? Is it 10%? Like, what is the barrier of entry there?
In terms of causing the plaque to rupture?
Yes.
That's a fantastic question. And cardiology is working hard to figure that out. We know a lot of mediators. I mean, there's a lot of like inflammation's a big one, right? In a general sense. Now, what are the exact inflammatory chemicals or mediators? There could be entire, courses, lectures on that. But for the sake of this episode, this show, inflammation does destabilize that lining. And actually, as a counterpoint to that, that's where one of the benefits of statins. Statins, in addition to that cholesterol medicine, they're known as statins, they lower HDL, and they also kind of protect that lining. They stabilize that lining so that it's less likely to rupture. So there is a little bit of kind of an anti-inflammatory effect when it comes to coronary arteries from that class of medicine. So when I recommend statins for people when appropriate, I'm not thinking just about LDL reduction. I'm thinking about plaque stabilization. If we had a chemical or an agent or a technique that could totally remove plaque, that would be great. But we don't really have those. Once it's there, and we want to stabilize it, slow progression, maybe cause regression. That's another. That would be ideal, is if we could cause those plaques to go away, but we don't really have that technique yet.
Gotcha. Okay. And so then are there differences in like symptoms between men and women when it comes to having that rupture?
Absolutely. So what are we actually feeling when that happens? So when the blood clot forms and the amount of oxygenated blood or oxygen getting to the cells, to the heart muscle cells, is interrupted or limited, we start to feel what a muscle would feel when it's having pain. So the guidelines have gone away from us using the word pain. We used to say, "Oh, are you having chest pain?" But chest pain means something different to a robust, tough guy like you, or like a Marine. or a woman that's had, given birth to children. Like the idea of pain is totally different, right?
That's fair. Yeah.
So pain is a misleading word, and I never asked that, but it'll almost be like people describe it as a discomfort, an ache, heaviness is classic. Typically in the classic description of this, you'll feel it in the center of your chest, and it often goes, you feel this like numbness or discomfort really in the left arm, sometimes up into the left or, bilateral neck areas.
Okay.
A really characteristic feature of this is that it gets worse when we start to move around. So if I'm having a blood clot in my coronary artery and portions of my heart muscle aren't getting enough oxygen, if I start to walk around, my heart muscle is going to beat faster. It's going to need more oxygen, and that should exacerbate the symptom complex, right? Yep. Imagine like if you were exercising, one of us was exercising, and I just like was able to clamp down on the femoral artery and cut off some of that blood. Imagine the discomfort in your leg, right?
Oh my God. That'd be very, very painful.
Very, very uncomfortable, right?
Very uncomfortable. But sorry, not painful. That's right. We're getting away.
No, painful. Yeah, it's not. Don't sign me up for that, right?
So, gosh, the only thing I can think of is trying to do like a leg extension, and somebody's just clamping down on that. I'm like, that would be terrible. I'd hate it.
Yeah, it'd be lights out, So that type of discomfort, that's the classic form of, the medical term for the symptom that people feel is called angina. And again, that's an old timey term. But that's sometimes what we say, like, do the symptoms sound like they're anginal in nature, which would be different from like, it hurts on my chest wall when I rub it, or like I had the way if I was lifting something, I have a chest wall soreness. I wouldn't call that angina. Angina specifically refers to that deep discomfort coming from the heart muscle.
Okay.
And interestingly, like you were sharing, and the guidelines are wonderful on this. American College of Cardiology gave an update a few years ago where they talked about different groups of people that experience a heart attack or interruption in oxygenated blood to the heart muscle. They experience that symptom differently. So, women tend to experience it differently. Elderly tend to experience it differently. People who have diabetes tend to experience it differently. And the diabetes part is because diabetes can also affect the nerves. So how that signal of discomfort or, trouble is transmitted is altered through these nerves that may be damaged in diabetes. And you want some history on how this kind of came about?
Oh, I'd love it.
So it was like 60s, 70s, sometime around that era, when we started to understand this as a disease process, heart attack, plaque rupture, coronary, an acute coronary syndrome. These are all interchangeable terms. People were documenting, okay, what are you feeling when this is happening? Because we identified them with clinical tools that we had, like an EKG or sometimes an echocardiogram, mainly EKG though. But the people that were examined were all like 55-year-old white men. Mm-hmm. And that's another group. Minorities experienced this experience differently. So for decades, we just said, well, everybody must be experiencing this the same way. And in the late 90s, 2000s, we saw the cardiology community saw that if a woman comes in with the exact same coronary artery that's involved in the heart attack, like exact same clinical scenario, at least anatomically, they were at least 2 times more likely to have significant damage or die from this.
Wow.
Yeah. And scientifically, people examined this and they said, well, okay, could it be a hormonal thing? Could there be a biological differences? And certainly there are. I mean, the biology is somewhat different. But what it came down to is that women were experiencing their symptoms differently. They were expressing them, explaining them differently. So the providers had a hard time saying, oh, that sounds like a heart attack. So we didn't go down that investigative pathway.
Yeah.
So it's kind of a cool, like, hey, we have to listen to people. We have to understand what's happening to them.
Wild.
It's crazy, right? Why in medicine would we listen to people? That's just,
makes no sense.
No, it makes no sense. Like, you have these degrees. Why would we listen to you? But it was a real triumph because, yes, of course, there's biological variation, but that idea that, oh, wait a minute, people are not going to describe this symptom the same. And so that kind of led this work into saying, well, how do other people feel this? So, women may feel it as more of a vague discomfort. Sometimes it's felt as an abdominal pain. A big one I hear, and this is not to be alarming to your listeners, but oftentimes people say, doc, I don't feel right. There's something, I just don't know what it is.
Yeah.
They're very rarely going to say, come in clutching their chest saying, I have chest pain.
Gotcha.
That's not often that's not often how people will say it. Now, sometimes they do, but yeah, we just have to listen a little harder. And then, is it worse when you move around? I had a person call me one time and said, hey, I'm having some chest pain. And they said, when I walk to the door, it hurts more. And I was like, okay, call an ambulance, like you got to go. And it was a heart attack,
Dang. Yeah. Okay. So that's kind of like one of the big ones then, is if somebody does come to you and they're like, hey, I'm having something going on like in my chest, is the movement's kind of the big question then, is like, does it get worse if you're moving? And that's usually how you can tell, okay, something's going on with their heart.
Right. And the way we would say is it's worse with exertion. And that kind of makes sense. I often think about the heart like an engine in a car, and the coronaries are fuel lines. So if my fuel line is clogged, if I step on the accelerator and I'm trying to go faster, but I can't deliver fuel faster, that car is not going to perform. And I'm not recommending that if somebody thinks they have a heart attack, go run. Just like maybe walk around a little bit,
Yeah.
Not wise.
We are not suggesting that you do that. That is that's a quick way to other unfortunate circumstances.
That's right. Things that we don't want.
Yes. Okay, great. Well, that is some really good information. That's good to know. The movement one is one that I hadn't really thought. I don't think I had heard that yet. So that's a good food for thought. Yeah. Yeah. Cause my dad, he's had stents put in. These were like, I want to say at least like 10 years ago. Cause he's had a heart attack already. Oh. Back when I was like in middle school and high school. I can't remember. I want to say it was high school, but yeah, that was a, scary time for me as like a kid, seeing my dad have that happen. I had to take him to the hospital and get some stents put in, but I found out that like heart issues kind of just run in the family. So these are kind of some of the questions that have been, on my mind for a while that, it's good to have answers to. So yeah. So then kind of following up along this, how much, because exercise is one thing that I'm, obviously I do for a living. It's something that I try and encourage other people to do. So how much exercise would you recommend to help kind of keep your heart healthy? And can too much of it kind of be bad for your heart, whether it be short-term or long-term?
Yeah. So there's good guidelines on this. And there's a little difference between if you've had an acute coronary syndrome, a heart attack, also another term we use for that is myocardial infarction. Mm-hmm. Then what I'd want to see is somebody go to something called cardiac rehab, which is a wonderful 3-month program. And this has been studied. It was devised by researchers, I believe at Duke, in collaboration with other universities. And this is a way to like rebuild the heart after you've had a heart attack, after there has potentially been heart muscle damage. And that's programmed. They build up on it. They give you nutritional guidance. They give you support. Wonderful program. So anybody who's had a heart attack, received a stent, even if they received a stent for not for a heart attack, but just for stable blockage, cardiac rehab is for sure the first. I always recommend it in those scenarios.
Yeah.
Now, for somebody trying to stay healthy, and then once they get through cardiac rehab, you want to be using that heart muscle, right? We have to use it. It strengthens. It's a really beautiful thing, right? Like every other substance in the world, the more you use it, the more it weakens. But the human body, the more we use it, the more it strengthens, right?
It truly is an incredible thing. It really is.
Right? It's really, you gotta like take a step back and marvel at that. There's just not anything like it.
Yeah.
And we'll get to that. You can overuse it too, potentially. So in general, like what I want to see is people hitting a good 120 minutes of cardio a week. There's been some good data on interval training, but it's not as prime time as some of the other basics that we know. So, getting that heart rate up and getting real specific about the zones. I often stay away from that because that data kind of changes as well. But that exercise level, and even walking is great. It's relative to where you are. If somebody's fairly sedentary, if you're doing 120 minutes of walking a week, to start off, and then you're like, hey, I like walking. I'm going to try jogging 10% of that. I'm going to try jogging a quarter of this and see what happens, which is what I did. I would, when I started running, I was like embarrassed. I was like jiggling. I hated myself. A lot of things going on. It hurt. But then after a while of doing it, I really started to enjoy that running. Like, I used to think, oh man, when is this first mile going to be over? Because I want to be done. Now I'm like, when is this first mile going to be over? Because the joy really started somewhere after that first mile. Sometimes runners say the first mile always sucks because you're just getting the rust out and you're finding your stride. But people will build up over time as long as they start doing something. And what I like to see is at least 120 minutes of cardio. Biking, running, swimming, anything like that. Resistance. Go ahead.
No, I apologize. I was just going to say that I feel like I kind of agree with you on that sense. Like getting around 120 minutes a week of cardio is always a good thing to be doing. Keeping your body moving is huge.
Absolutely. And the resistance part has come up quite a bit too. I think also as we have an aging population and people who are aging and trying to, they call this health span, right? It's not lifespan as much anymore. Not how long am I going to live, but how many quality years am I going to live? So strength, resistance, proximal muscle development, these things are all really important too. And for cardio, not just in general, but for cardiovascular health. So, 2 to 3 times a week of some sort of resistance training, and everything is progressive. So.
Yeah, I think that you bring up an interesting point there with the idea of like health span and how muscle will affect the body as well. This may be kind of like a dumb question, but the difference in the amount of like fat mass you have compared to the amount of muscle mass, how does your heart differentiate when it comes to how hard it has to work to pump blood throughout your body, to like whether somebody has a higher body fat percentage versus somebody who has just like a higher muscle mass?
That is a fantastic question. Because the vasculature, that's the blood vessels and the makeup of how that network of blood vessels is different for different types of tissue. Mm-hmm. I don't really know the answer to that, but I am going to look that up. You sparked my interest because I've thought about this, but I've never looked at it from a mechanistic standpoint. Yeah.
Perfect. Yeah. Well, hey, I appreciate that honesty there. And I would love to follow up because it's something that I'm curious about too, because you brought up a very good point of like how muscle mass definitely plays a part in like the longevity aspect. That's one of those things that I know as studies have come out, it shows the more lean muscle mass that you have, the more quality years of life that you can have.
Oh, absolutely. Yeah. That's a great point. When people are trying to figure out what's my, sometimes we call it cardiometabolic risk. What's my cardiometabolic risk? People talk about visceral fat, right? That's a term we hear a lot of. So even if people have subcutaneous fat, which has for a long time been, we assumed a surrogate for visceral. Viscera is just another word for organs, but for organ fat, which is really, that correlates more to the presence of cholesterol in the arteries. That's something that has been really well studied. Where is your distribution? Where is the deposition of fat? Because fat, if you're in a body that tends to deposit fat around the organs, that's associated with a higher risk of cholesterol-mediated cardiovascular disease, which we call atherosclerosis. That's a term people probably have heard. So that's another thing, to look at that and what are the maneuvers I can do to decrease that body composition type of thing.
Yeah.
Plus, I mean, we can nerd out on this because I like this, and this is not clinical. This is more just, Rishi and Jack talking, but what are the different types of tissues may send out different types of chemical signals, different types of messages. So a body that has a lot more muscle, are there actually signals coming from the muscle that have benefit to vascular health? Are there signals from the fat tissue that when released have deleterious effects on the vascular health? Those are, I'm sure there is research into that. But again, that for me is more on the basic science side and less on the clinical side yet. But that stuff is in the pipeline. And, I don't want to talk about it too much again, because I'm not an expert in that basic science aspect of it. But totally it's intriguing. Good questions. Yeah.
Yeah. No, and I think that's totally fair because it is, I mean, there's definitely been from my own personal and even some professional experience, like there is a very evident case of like having more lean muscle mass, how it affects like even just hormones in general compared to somebody with a higher body fat percentage. The hormones get completely thrown out of whack the higher your visceral fat count is. Even subcutaneous, if it's too high, your hormones get kind of put out of whack. So I am really curious to know what the difference there is in like what signals are being sent out from the different types of tissue. That's a really cool, that is an interesting thought.
Right. And that's all mechanistic basic science. It's, one thing that sometimes happens in the wellness space is so a researcher will identify something at the cellular level, and then it'll be extrapolated to the clinical level. But trials, especially in cardiology, because we have so much data, a lot of things that made sense at the cellular level, when we roll that out and we do clinical trials, we find that there's no difference, or sometimes there's harm from some of these things, like certain supplements and things. So my threshold for saying, oh, something mechanistically makes sense, to saying, hey, it's ready for prime time across the board in all humans, is my threshold's high, unfortunately, because not that people shouldn't try things. It just kind of depends. I'm always I hear something, I'm like, okay, there's a mechanism there.
Yeah.
But does that translate to actual improvement in our own, in individuals' health? There's a huge gap sometimes.
Totally fair. And I think that's a very valid thing. I think I'm probably more leaning towards that cautionary side as well, just because you have that, like the two different sides where it's like, if something seems like it could be good, that doesn't mean it is good for, human consumption or human test trials, if it works for animals or however the test studies kind of go. And so it's like, okay, you don't always want to just jump to conclusions because one or two people say, oh yeah, this, foreign substance worked great for me. Yeah. Still got to be careful.
And, and the truth is, it could have that substance could have helped that individual.
Yeah.
The hard part is from a clinical side, if I'm thinking about how do I make recommendations to people in general, I think part of my responsibility is to really be as confident as I can about that recommendation. And if there's not enough evidence, I can't say, oh, it doesn't work. All I can say is, I just don't have enough evidence about that situation. And if there's harm or something that I am aware of that's harmful, I'll of course provide, counsel or caution regarding that. But yeah, it's exciting. And I think we're going to have a lot more information about these things, even about nutrition. I'm very excited to see this boom in nutrition research. I know we're going on a tangent, but nutrition studies are really hard, right? There's the Mediterranean diet is often cited in cardiovascular literature. And there's only a handful, I think 2, maybe perhaps 3, that have done this the right way, where a lot of food studies are diaries or self-reports, which, I'm not sure that a self-reported intake of my food log is the most accurate. But if you actually prepare the food and give it to different groups, you can see a difference there. So nutritional studies are a little bit more challenging too.
Yeah, I agree. Yeah. And I'm right there with you. I think I'm loving the way that I think science is starting to progress and all of the new studies that are coming out. So yeah, tangents are bound to happen. I think every single video has me going off on a tangent at some point. So, but yeah, so then to kind of bring us a little back on track, I am curious because one thing that I think mentioned was atrial fibrillation, I believe it is, otherwise known as an AFib. So what does it mean exactly when your heart is beating out of rhythm?
Oh, great question. So maybe I'll take a step back with this too and talk about what's normal. When we talk about the normal rhythm in the heart, we have to think about how the heart is designed. And I almost wish I had a picture of this, but there's 4 chambers. I should have a heart somewhere around here. I'm not in my office. I do have a model. But there's 4 chambers. The upper chambers of the heart are called the atria, an atrium, an entryway. So they're the entryways to the heart. And the bottom chambers of the heart are called the ventricles. The majority of the heart muscle is in the ventricles, particularly the left ventricle, which receives blood from the lungs that has oxygen in it and pumps it through the arteries to the rest of the body. Mm-hmm. So really the whole purpose of the heart is to get that oxygenated blood and pump it to the rest of the body. But the atria are what let blood into those ventricles, the entryway to the ventricles. Now, in a beautiful, design in the heart, or the heart is it just has developed in this beautiful way. Right before the ventricles contract, which is the pulse. So when I feel my pulse, what I'm actually feeling is the left ventricle pushing blood through my arteries. Right before it contracts, the right and left atria both squeeze. Right atria pumps into the right ventricle. Left atria, receiving blood from the lungs, pumps into the left ventricle. The right atria receives blood from the body veins so that it can fill the right ventricle, which then pumps it into the lungs and then circulates back to the left atrium. So these atria, right before the ventricle fills or contracts, they squeeze like a primer pump to eject whatever residual blood is in the atria to optimally fill the ventricles, which is a great advantage to have, because the more blood we have in the heart, in the ventricles, right before we contract, the more blood that comes out with each beat. So it's a good advantage to have these little primer pumps. Yeah. Now, in order to do that, the heart has to beat in sequence. The atria have to contract before the ventricles. Does that make sense?
Yes.
Primer pumps pump before the major pump fires. And there's an electrical network inside the heart that causes that timing sequence to happen. Kind of like in a car, right? Like with spark plugs, there's a timing sequence. And so you have this area in your right atrium, which is the natural pacemaker of the heart. It sets the sequence it sends the signals for the heart to beat in sequence. So the atria pump first. There's a 200 millisecond delay before the ventricles pump to allow the atria to squeeze and thoroughly fill the ventricles. Now, if the atria didn't pump, 75% of the blood will just flow right through. This is just the primer pump to give a little extra blood into the ventricles. So the atria pump first, ventricles pump second, and there's an electrical signal that tells that to happen. And that's the normal rhythm. Atria squeeze, ventricles fire afterwards, okay. A ventricle squeeze after that. Does that part make sense?
Yes.
So what happens in atrial fibrillation, because this electrical network is so embedded in the entire heart itself, so both the atria and the ventricles, if there's some scarring that happens inside the left atria, so one example is high blood pressure puts some strain on all the chambers of the heart. The atria kind of get bigger. They have to deal with a higher pressure. And so as a result of that, instead of having this really smooth, slick electrical network, there's scar tissue, like microscopic scar tissue that forms inside the atria. So instead of having an atria that's smooth like this, you have one that's got gaps. And almost like in a filament, if you look at a wire and you jam pieces of cotton into that wire, it's not going to conduct the same way.
Yeah.
That makes sense. So a scar is like that.
Gotcha.
And what happens is, instead of having that normal pacemaker in the right atrium send that signal, the electrical signal scatters throughout the left atria, throughout the atria. And then the left atria, instead of having a coordinated contraction, is fibrillating. So it's just kind of jiggling or wiggling. Blood is still getting into the ventricles, but the atria itself is fibrillating. And the signals for the ventricles still to contract still follow in a little bit of a disordered sequence, but they still beat. Like atrial fibrillation doesn't cause cardiac arrest or the heart to stop.
Yeah,
it can't cause other problems. But once that happens, that normal like heart rhythm is out of whack. It would be like again on a distributor system in a car. Like if all of a sudden the spark plugs just started to fire whenever they wanted.
Yeah. Okay. So then do you think, regardless, like when it comes to like kind of a client, I guess, dealing with an AFib, do you think it's better to kind of just take meds long term or something like an ablation to fix it?
Oh, this is a great question. And then going back to so what is somebody going to feel? Because that may have been a little technical, but if the heart is out of rhythm, instead of having beats that are happening regularly every second, bump, 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 normal rhythm, right? It's the time between beats is pretty similar. Maybe like bump, 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 it'll be chaotic. And about 50% of people actually feel that. They feel like a washing machine, or they feel their heart beating. 50% of people don't even feel it at all, which is amazing. So it can make checking your heart rate hard to determine, because the heart rate can just take off for no reason. Yeah. Other times it can be an AFib in the normal rhythm, but the normal rate. So it can be a little bit tricky, and 100% need the guidance of a cardiologist or a doctor to help manage this. Medications are important. They have a role. In my opinion, for the right person, so somebody who has AFib and they are feeling symptoms, Ablation is a good early step because as AFib gets worse, you get more and more scarring. So as it starts to, somebody may have one episode and then it terminates on its own. And then I would say, okay, you know what, let's maybe use some meds. Let's watch, see how things are going. And maybe it's 2 or 3 years before they have another episode. But then they have that second episode and it starts happening twice a year or 3 times a year. Once it starts to pick up in frequency and they're having symptoms, I think ablation is it's a good consideration because you're actually modifying the atria. You're saying the areas that are where the AFib is the worst inside the atria, let's try to control it or contain it in that area. As the AFib gets more and more predominant, it's almost like a wildfire that slowly builds. So if it's just a small fire in one area of the atria, well, let's put a controlled burn around that so it doesn't spread to the other areas. But now you got a fire over in this side and this side and this side. And then before you know it, the whole atria is fibrillating all the time. It doesn't come out of it.
Yeah.
But that's later. I mean, this doesn't happen overnight. This progresses, over months and years.
Yeah. Takes a long time. There's usually signs and repetitions and patterns that somebody could pick up on or get checked out before it happens.
And monitors are great, so we can actually determine, oh, you're an AFib 10% of the time, or you're an AFib 90% of the time. That can help guide some of the recommendations we'd make.
So then regarding those, and this may be a dumb question. Does somebody's like heart rate variation, their HRV basically determine whether they are more likely to have an AFib or not? Like somebody with like a low HRV versus a higher HRV.
That's another great question. I don't know the science. I don't know the data behind low heart rate variability predicting AFib. That's another something I'd have to look up. It does make sense though, because again, mechanistically, the autonomic nervous system, the parasympathetic nervous system, and the sympathetic nervous system, those are really involved in the mechanisms of AFib. And there are some researchers, like one of the earliest ablating cardiologists, has really moved now to doing his research largely in vagal nerve stimulation for atrial fibrillation. So there's for sure a mechanism and an association between parasympathetic function and AFib, but the exact relationship and how we can modify it, I think, is still more in the research realm. But that guy is amazing. He's a fantastic cardiologist. Dr. Jackman.
I'm sorry, what was his name again?
Dr. Jackman.
Dr. Jackman. Okay.
Yeah, and so he's done a lot of work in vagal nerve, I think it's an auricular vagal nerve stimulator in treatment for people who have AFib. So, the role of the parasympathetic nervous system or the autonomic nervous system in AFib, that part is known, but does low HRV predict AFib? That I'm not sure of.
Gotcha. Cool. Gosh, well, I'll definitely have to check them out. I'm really curious now.
Yeah, there's so many. These are the great questions that come up, and then if it is associated, then the next question is, if we modify it, do we protect people, right? That's the real question, is then if we find that association and we find that it maybe is even causal, like there's a causal relationship, then what do we do to modify it, And then how we modify it, does that cause another problem that we have to worry about,
Yeah.
Because like you said, we didn't really address this for coronary disease, but there is too much cardio. There can be, right? So ultra marathoners tend to have a higher rate of AFib. They also tend to have a slightly higher rate of coronary artery disease. Now, this isn't true for, most of us normal folks who are doing regular exercise, or even people who do the occasional marathon. But people who are living that ultra marathon life, they do have accelerated forms of cardiovascular disease, including AFib.
Interesting. Okay. Huh. And so then do you have information like why that is? Like, is it just due to like the amount of stress output that they're constantly putting on their bodies?
That's the theory. So the one of the early the cardiologists that did a lot of this work early on was Dr. James O'Keefe. And he actually has a couple of TED Talks out there, which are really nice to listen to. These are old too. These are over maybe 10 or 15 years old. But he started to notice that in ultra runners or people who are exercising. And, his story is great too. He talks about how he used to run all the time and he scaled back a little bit as well. And I think the thought is that it perhaps accelerates some of the wear and tear, because what he saw was on these coronary artery calcium scans and coronary CTs, he would see a high degree of cholesterol deposition in those arteries, a higher degree of atherosclerosis in people who seem to be quite healthy. So that's what made him kind of scratch his head and say, why is this? And so now we think that there could be this upper limit of running. Some large scale epidemiologic studies have looked at it and said, where is that? Is that maybe 20 miles a week? That number has been suggested in some data from a few years ago. That also was, I think, 5 or 10 years ago. That study came out of Europe and countries that have large scale databases. But that, again, I don't know the exact number, but there is definitely, you can end up doing too much. Most of us aren't getting close to that, though. So I don't want somebody to say like, oh, this cardiologist said I shouldn't run. But if you're starting to do ultras or marathons all the time, then probably talk to your cardiologist. But,
yeah. We do recommend running. It is a good thing for you. But
yeah, good cardio. And weirdly, I don't think it's seen in the endurance athletes in other sports. I like cycling. I don't think it's quite as prevalent. I'd have to go back and re-review the literature on that, but I remember it being more evident in runners. So also, is there something about running that is adding to it beyond what a cyclist does? Because you can definitely get way more miles on a bike than running, for sure.
Yeah, very true. Yeah, that is really interesting. Those are some really good questions and just curiosities that you've piqued.
Yeah, this is the beauty of it, right? It's like you learn this stuff and then you're like, oh, I wonder about that. Now to find that answer out, it takes research labs and decades, but these are it makes you wonder, right?
Yeah, it's both like I think the challenging part and like the fun part of science is it's such a growing field that like there's always like questions that keep coming out and coming up, and it's like, oh, I'm so curious. Like, okay, what studies are there out that go over this? And so it's I love it. You always have something to learn.
Oh, and before I did cardiology, like when I was learning it for my first 3 years, and honestly, even my first 5 years out of training, I just I would think about things, but the way I think about questions now it's really fun. It's like, okay, because I think about this all the time, right? I'm driving home and I'm like, oh, I wonder if adipose tissue is releasing some factor we don't know. It's all these questions that come up after just you spend your whole life thinking about it, and then I go back and wish. I wish I had been more thoughtful as a med student, so I would have started a research lab. But you don't know what you don't know at that time.
Very true. Yeah, very true.
Or at least I didn't. But.
Awesome. Well, so one more question for you, if you don't mind.
Sure.
I'm curious. Kind of, we slightly touched on it a little bit, but regarding stress. So, what is actually kind of going on in the body, or in the heart, I should say, when long-term stress leads to more heart problems? Like, how does I guess chronic stress affect the heart?
Yeah, great question. This comes up a lot in the most direct, or in the most concrete way. It's through indirect mechanisms. So chronic stress leading to the behavioral things that lead to coronary artery disease, and specifically, I'll talk about that, the atherosclerosis. So the more stressed I am, and I'll use myself as an example. If I'm not feeling great, right, and I've worked a lot, or all this stuff is going on, what I sometimes like to do is turn Netflix on, zone out. And when I turn Netflix on and zone out, I'm not eating broccoli. I'm eating cookies and popcorn and those types of things, right? And then that may go on for a little bit, and then it's sunny outside, and I may not go for the walk that I normally would, and then I'm up at night and I'm not sleeping, and we know the importance of getting into deep sleep and getting into that restorative cycle. So then now I'm burning the candle at both ends, right? I'm ingesting a lot of things that are ultimately going to be damaging to me in aggregate, and then I'm not giving myself time to clean those things out, to recover, and I'm avoiding the things that are building my body, like exercise. And so the behavioral changes associated with stress are often the same behavioral thing, the same behaviors that lead to the buildup of cholesterol in our coronary arteries.
Gotcha.
Now, when we start talking about cortisol metabolism and those impacts, certainly, cortisol has, significant negative metabolic impact, right? And its associations with fat deposition and coronary disease. So of course those mediators are going to be there as well, but it's almost like in a way cortisol is the smoke and the fire is, the behavior, right? Or is the situation I continue to put myself in.
Mm-hmm. That is a really interesting way of thinking about it. I don't think I've ever had that analogy before. That's a really good one.
Oh, smoke and fire. It's one of my, I love it. Like coronary disease is the smoke, the fire is like how we live our lives. And it's understandable. I'm not, the world is tough. And some of these, it's not like I'm going to tell somebody never to eat a donut. An intentional donut is a fantastic thing. An intentional steak is a fantastic thing. It's just when I get into those patterns where I'm doing it over and over.
Yeah. Yeah. And I think that intentional part that you mentioned is a really big key part, is because, if you're accidentally doing these things, they're usually happening over and over again. But that intentionality behind it, where it's like, okay, I know what I'm doing. I'm just going to do it this one time and put my restraints on after that, or, have it all in moderation.
Yeah. Like the movie analogies, I like it. Like if I'm going to the movies, I'm going to get popcorn. I'm going to probably put some candy in that popcorn. Like I'm going to the movies for that reason, but if I go home and say, what would be a great dinner is like popcorn and candy. Like that doesn't make as much sense, right? Like,
a little bit less there. Yeah.
Right. Like I'm going to eat poorly and then I'm going to have celery at the movie theater. It's like, Yeah.
No, but I don't, that sounds just diabolical. That just doesn't.
Yeah. Well, right. No, that's not a life I want to live.
Yeah. I'm at the movies. I'm not eating celery. Sorry.
No. I'm not a robot. I'm not an android.
Yeah. I still like to enjoy life a little bit,
Yeah. And we should, right? Because isn't that part of it is I think too, with the health journey, one thing that kind of became apparent to me, and discipline is important and it's in its routine. I think discipline I always thought of is like, I need to go to the gym and like, I need to do this hour-long workout. But I think the vast majority of discipline for me has been showing up to the gym, because depending, I'm 43 years old, depending on how my body is functioning that day, I'm going to get different types of workouts in, but I got to the gym and I did something. And that consistency that results from discipline is what makes the changes. This idea like, like I have to make it all be about discipline, I think is sometimes for me gets a little bit challenging, because then I'm resisting all these things, right? So there's this discipline or what do I need to be disciplined about? Getting to the gym, the behaviors, not the outcomes. I need to be disciplined with the behaviors, not the outcomes.
Yeah. Yeah. I love that. I couldn't agree more.
No, I mean, this is your world, right? Like, so, like you see this way more than I do. You're dealing with people who are interested in their health, right? Mm-hmm. And discipline's often an issue.
Oh, definitely. Yeah. Yeah. Whether it's just discipline getting in, discipline doing the stuff outside of the gym, even like we talked about that cardio, just 120 minutes. Like I think getting even just like the 10,000 steps a day as like a baseline tends to, like, it still requires a little bit of discipline. And it can be hard for some people to build that discipline. Right.
Right. And not go after like, because I think like this, I'm like, I want the maximum amount of discipline right now. I want it yesterday, But discipline, like anything else, is built, right? It's like a little bit of discipline, then a little bit more. And then, that discipline then kind of fades away as a concept. It just becomes your nature, When I, in my health journey, when I was a lot unhealthier, I didn't have any discipline, but discipline has helped me, because now in a way, when I don't work out is how I used to feel when I did work out before. Like it's uncomfortable to me, so that discipline, it almost becomes less necessary, not because I enjoy working out, but because my body has adapted to health instead of being maladapted to poor health.
Yeah. I love that. And I'm really happy to hear that, because when that is like the golden ticket right there, when you can get to that point where when you're not working out, it feels uncomfortable. When you're not exercising, when you're not moving your body, it feels uncomfortable, because that's really how it should be. That really is.
It's what the human body was designed for, I used to like hate those people, and like, it's not, and maybe look, it may not be everybody's journey, and I get it. But it is kind of interesting. I think that in general, the body, like when we were kids, like we kind of most of us just effortlessly moved around. A lot of us at least were like that. And it doesn't, not everybody's going to be, I was not an athletic kid at all. You know, I tried to be, I wasn't, and some people were, but you know, still doing those things, still getting outside and running and playing, all that stuff.
Mm-hmm. I love it. I agree. Yeah. Well, Dr. Rishi, I appreciate you so much, friend. I'm really glad that you were willing to come on and do this. It's been so nice talking to you. And you've answered a lot of questions. You've given me a lot of good things to like think about, get to go do some like research on, and then follow up with you and just see how you've been doing as well. So thank you so much.
Thank you, Jack. I love what you're doing. I'm really grateful that you're doing this for the community. You're great show that you're running here. And
thank you.
Hopefully that stuff made sense and it doesn't cause more questions, but I always love seeing you. I look forward to seeing you around and like pulling up papers together and figuring things out, man.
Definitely. Yeah. Well, and I'll be honest, I'm sure it probably will give me more questions. I'm always that type of person to look back at things and just be like, oh man, like how did I not ask that question? Why didn't I think of that? So that's just me though. But yeah.
I love that. That's the best. Nothing's better than curiosity, my friend. That's a gift.
Yeah. Well, thank you so much. And I appreciate you. And I hope you have a wonderful, wonderful week.
You too, man. I look forward to seeing you around real soon.
Awesome. Thank you so much.
See ya.
Bye.